I'm Joni Hornbeck. I'm the Clinical Acuity Coordinator for Carle Health, an 8-hospital system in central and southern Illinois.
Hello, everyone. I am Deb Kolakowski. I am currently the Chief of Oncology and Critical Care at the National Institutes of Health Clinical Center. I've been working with Acuity here at the NIH Clinical Center since 2008, when we made the decision to look for a product that would give us measures that were data-driven, based on patient needs, to be able to support our nursing staff and our patients, as opposed to what we were using back in the day, using nurse-patient ratios.
How are you using Acuity to drive staffing assignments?
We leverage the Acuity tool's workload totals and calculated recommended hours to create equitable assignments for nursing staff. This does mark a shift from the previous ratio-based approach. Now, although the number of patients per staff member might vary within a unit, their workload totals are aligned. When making the daily staffing decisions from an operational level, we also consider overall unit acuities, particularly among similar units. This helps us efficiently allocate any extra resources to the units that need them the most.
How has an Acuity-based workflow solution supported nursing excellence?
I think the biggest impact has been with the nurses at the unit level. They are involved. They ask questions that are acuity-related questions. They go and they look to see how their patients are being classified to make sure that we're not missing something. And it's really the language that has driven us to a new level when we talk to the staff about acuity. It also has provided us a validated, reliable nursing workload measurement when we go to budgeting for each of the different areas. We have a budgeted hours per patient day, but we look to see what is recommended. And as long as what is recommended is valid and it has greater than 90% reliability, then we will go with what is recommended because it is based on the acuity on that particular unit. And we can see the variation in acuities based on different clinical units. And so we can see the differences, we can explain the differences. And so that has given us the language to be able to speak to what the nurses and the patients, most importantly, need at the unit level.
How have Acuity-based assignments changed the culture of your organization?
The transition to acuity-based assignments is increasingly favored by our nursing staff over traditional ratio-based assignments. This change reflects an understanding that patient needs can vary significantly, even within similar patient populations. Our staff now sees the value in these assignments and expect them as part of their routine. Instances where assignments weren't made using the Acuity tool have been formally reported by staff who felt the outcomes would have been more equitable had the tool been used. This shows a growing preference and trust in the acuity-based approach.
How has being able to capture and compare acuities in varied care settings led to new processes?
So one of the things that we look at is how we are able to capture and compare acuities across varied care settings that led to any new processes, any changes that we've been able to incorporate. And there are a few. It prompted our nursing leadership at the unit level to look at recommended versus actual hours per patient day in comparison to what is budgeted. And so every year, when we go into budgeting, we look to see what that unit's recommended hours per patient day was at the end of the year, but we also look at the trends month by month, because there are some seasonal changes that we've identified in some of the different clinical areas. And so we will take those recommendations and use those for budgeting, which then results into hopefully the right staffing numbers for that unit, again, based on acuity. What really has been instrumental recently is Cognos. And Cognos is being used by unit leadership, but we're going to be getting it, we're going to take it down as far as the charge nurses on the unit, so that the charge nurses on a shift-to-shift basis can make staffing decisions with our off-shift supervisors, but that the unit leadership, before they even leave for the day, can look to see what the acuity trends have been, what the acuity is predicted for the next couple of shifts. So by the time they come back in the morning, we do have the right staffing numbers for the unit. And if there is, if our staffing numbers show that we're over, that potentially we can help our colleagues who may not be in a good staffing position. So Cognos has been really good. It's making people ask questions and looking at their data at all levels on all shifts.
How has an acuity-based solution supported the provision of specialized care across unique care settings?
Well, I like to think that we're unique because of the work that we do with research, and we are, but we do compare ourselves to academic medical centers as well as community, because we're a smaller hospital, but very, very specialized. For instance, in our critical care area, we have workload that's associated with the staff going off the unit to go to codes or to go to rapid responses, or to be able, we actually have our critical care nurses who will transport patients outside of our hospital to a hospital across the street. And so we capture all of those activities where that nurse who actually had a patient assignment has to be pulled away to be able to do another activity. And so we look at those as an other workload activity, and we're able to differentiate the care in the critical care area in that way. That's only one example of how we would do other workload or 1+ RN activities. So the use of these other workload indicators, which is also called continuous 1 hour plus activities, differentiates the care at the bedside for these higher acuity type procedures that are being done. So for instance, on our medical oncology, as well as our day hospital, we do a myotaps to be able to administer chemotherapy or to do some lab draws. And that requires a nurse to be at the bedside for greater than an hour. It actually involves 2 nurses to be at the bedside for greater than an hour. That nurse could have another patient that somebody else would be covering, but she's in that room. And so we can capture that activity of that nurse who's in that room for an hour, and the care of that patient requires a 1-to-1 assignment. So that's one way we can look at other workload, and we can differentiate which of our areas really has a higher workload associated with, I would say, these 1+ hour activities, and then dive into that a little bit further.
With the solution you use today, how have its benchmarking capabilities helped you?
As a newer client using the tool, our benchmarking is likely more novice. However, the benchmarking capabilities of our tool have been instrumental in providing objective validation of our subjective observations. We've been able to confirm variations in acuities across different units and compare these both internally within an individual hospital, as well as across our 8-hospital health system as a whole, from critical access hospitals to tertiary care centers. This has been crucial in understanding and addressing the unique needs of each unit more effectively.
We use hours per patient day as our standard for a lot of things that we do for budgeting or for benchmarking. We use recommended staffing when we look on a shift-to-shift basis, what we should be staffed for. But the recommended hours per patient day, actual hours per patient day compared to budget really drives a lot of the decisions that we make. What we get from benchmarking is we get the ability to critically assess our operations and to really ask what are the clinical care differences in a research setting from other institutions. We specifically will benchmark and look at things such as census, admission, discharge, transfer data, classification and overall acuity, complexity, recommended staffing, as well as recommended hours. So there's a lot of data that you can get from a benchmarking perspective that makes you ask the question. It's the clinical inquiry that I think is, for me, the most fun part of it, to not always know the answers, but to really go out there and try to find the answers about the best way to be able to support the staff as well as our patients here.